Okay, we've reached the end of this conference. Angela, as I said this morning, you have to stay all day, you have to stay to the end, and you now have the very tricky task of concluding. Either you can do it here or you can go to the lectern as you wish. Thank you very much.
Thank you very much. And it's impossible to summarize all the fascinating insights that we've heard today. So I'm just going to pick out a few points that seemed important to me that we've heard, and also one of two that we perhaps haven't heard and we may need to think about. So my question is, what have we learned today? First of all, we have talked a lot but not really defined what we're trying to achieve. Here's a definition of person-centered care, which comes from the Health Foundation, which is a charity in England. And they talk about three main aspects: that care that is personalized, care that is coordinated, and care that is enabling. And that around this is the requirement that patients should be treated with dignity and respect. Now, why are we talking about person-centered care? What are the problems that we're trying to solve with patient involvement? Well, the only way I think you can understand that is by looking at healthcare through the patient's eyes. It doesn't always look like that. But what it often looks like is a sort of disempowering process, something that denies the patient's capabilities and strengths and sees them as simply a passive victim of illness, undermining their own ability to look for themselves. Also, and we've discussed this a bit today, that healthcare, with all its guidelines, with all its regulations and so on, has become quite inflexible, quite rule-bound. And that runs up against the desire that many patients have for a much more personalized, individualized process, recognizing that all of us are different and may have different values and preferences. And then finally, as healthcare becomes more effective and there's more that can be done, it also becomes very complex and fragmented. And people who need multiple services can often feel lost in this complex maze. So what we're trying to do is to tackle those problems to help patients make the most of the valuable resource that we're offering them through our public healthcare systems. But as well as offering them a valuable resource, we must recognize that they themselves are a valuable resource, an untapped resource often. Indeed, they've been called the greatest untapped resource. Anybody working in healthcare will always tell you that their budget isn't big enough and so on and so on. But here we have a resource that can make healthcare more effective and improve its quality and safety, so we need to use it. And of course, there are many, many ways in which patients can make an important contribution to health. I've listed them there. I won't go through all of them. I've got another slide with another list. Let me show you. Many multiple ways in which patients make a really important contribution. And that contribution could be more important and strengthened if we organized our systems so that they did recognize and support those contributions. We've talked quite a bit today. Sometimes some speakers have used different words to describe it. I tend to use the word co-production or co-creation, seeing patients as part of the team who's going to help ensure the best quality care. And that means working with people, not doing things to them or for them. It means seeing people as partners in the business of health. And instead of asking, what's the matter with you, the classic question, we should be asking, what matters to you? What's important? What are your goals? How can we help you achieve those goals? So what do we know? HAS is of course a scientific agency. It's wanting to base all its processes on good evidence, and we've heard lots of good evidence today. an interesting new type of evidence, the evidence on how you can engage people and what the impacts are when you do it. A person-centered approach involves listening, involving, communicating, and so on and so on. It's complex. It's difficult to do. Health professionals need to learn how to do it. One of the problems we have in our systems is that there's an inbuilt conservatism into healthcare because it takes a very long time to train a doctor or a nurse or a therapist, and they are trained by older people who took a very long time to train, who in turn were trained by even older people who took a long time to train. So things don't change very quickly, and it takes courage to change the way people have been trained to think. And people working in healthcare are, of course, motivated to do the best for their patients. That's why people work in healthcare, because they want to do the best. But they may not be so able to look very critically at what they do and think, is there a better way we can do this? So a good system helps to untap that resource of critical thinking, and working with patients is a very good way to do that. And we've also talked a bit about health information and the importance of this to patients. In our European and North American countries, we have a very highly educated population, and almost all of them have access to the internet. They can find a lot of information, and many people do, like this lady here, because they want to understand their health, they want to understand what can be done about any problems they're experiencing. But what they tend to find is a rather over-optimistic view of healthcare. They tend to find a lot of information about the benefits of various expensive interventions and not much about the downsides, the side effects, the risks. So that tendency needs to be countered. That's one of the reasons why we invest in HTA, because we're trying to take an objective look at what really happens when you use a health intervention. But we mustn't forget that patients are also users of HTA, potential users, as well as contributors. And we heard about shared decision-making. This is one of the important ways in which patients need to use the products of HTA. And that means translating the evidence into very clear terms that people without any medical training, without necessarily a higher education, can understand. The good news is we do know how to do that. And Karen Sapuka talked about patient decision aids, which actually do that. They bring together the evidence and present it in a way that anybody can understand. And as I say, the very good news is that these have been tested with all sorts of people, including people without very much education. And there's a Cochrane review, which she mentioned, which shows the benefits of doing this. So we need to see patients as users of the products of the work that has been talked about today. Now, there's another big challenge, and this is the biggest challenge of all, I think, and that is that much of the work we do in HTA, in healthcare research, is very focused on specific interventions or specific diseases. But in the real world, much of the money that's spent on healthcare is actually spent on people who have multiple conditions. And if you look for studies of the effects of multimorbidity, and you think about, well, this patient who's got diabetes and arthritis and back pain and depression, what is the impact of giving them this additional drug or this additional treatment or encouraging them to take exercise or whatever it is? We actually can't find the answers to those questions because the research, the clinical trials that have been done are so constrained that they tend to be talking about patients who don't actually exist out there in the real world. So we're going to have to change not just the research we do, but also the way we work with patients to counter this problem, this fact that with aging populations, we are dealing more and more with people with multiple health problems and indeed social care problems as well. And that is a demographic change that is certainly affecting us throughout Europe and in North America, and it's also affecting the world. The rise of chronic conditions we estimate in England that 70% of NHS resources now go on treating chronic illness, not acute problems. Now, in chronic illness, health professionals often say, that their job is to manage chronic disease. They're wrong. They do manage chronic disease, but only a tiny, tiny, tiny proportion of it. Most of the management of chronic disease is done by the patients themselves and their families. We counted up the amount of time in direct contact with health professionals that somebody with diabetes or arthritis or whatever the condition is spends, and calculating, say, a fairly high use of healthcare might be one consultation lasting, say, 15 minutes a month. That amounts to 3 hours a year. Now, there are 8,760 hours in a year. That means 99.9% of the time the patient is doing the work. And if that is the case, then we need to reorientate our health systems to support the patients to do a better job of the work that they're already doing. So this means that the kind of conversations that you've heard a lot about today need to become the norm. The conversations that work with people, starting from their goals, and work from the idea that the aim is to help people achieve the goals that they themselves set. And they may talk about goals in very different ways from the health professional. So the patient may not come in and say, my number one priority is to reduce my HbA1c level or keep my blood pressure under control. They may not say that at all. They may say, what's really important to me is to feel well enough to go to my granddaughter's wedding, which is next month. And how can you help me do that? That's fine. That's a good goal. So we need to work with it. And we've done another Cochrane review recently, looking at what happens when you do involve patients in chronic disease management in this way. And the news is good. The news, there are fewer trials than there are in the previous one I showed you, but still we found that 19 trials where they had really tried to evaluate what happens when patients are actively involved in managing their condition. And the answer is it leads to better physical health, better emotional health, reduced rates of depression, for example, and better capabilities for self-management. And again, we've talked about Amartya Sen's ideas on capabilities and how important that is in managing conditions. And indeed, there's wider evidence. I've done quite a lot of reviewing the evidence on patient and public involvement. This is not one of my studies. This is another one that was published quite recently, where they looked at a whole range of methods and found similar kind of improvements. This is the way to improve health. This is the way to get better value out of the health care that we offer, to work with patients as partners. Now, I just wanted to say a word about measurement, because we've also heard a lot about that. And I think one of the things we have to be very clear about is what are we trying to achieve when we measure? There's a tendency nowadays to measure everything and then to think afterwards what can we do with those measures? It's the wrong way round. We need to think, well, what do we really want to know? And then let's select the right measure that will deliver the outcomes that we're really interested in. And there are plenty of reasons for measuring, and I've listed them on that slide. I just wanted to show one example from, I did say that I had been involved in getting the National Patient Survey Programme off the ground in England, and we've been doing this in a systematic way across the whole system, huge numbers of patients every year. So this is from the hospital inpatient survey, and one of the questions we ask, this is just an example, were you involved as much as you wanted to be in decisions about your care and treatment? Now, this is, you need to understand that this has been a top policy priority. It appears in every document, policy document over the last 20 years. And somebody mentioned the Salzburg meeting where they came up with the slogan, "Nothing about me without me." Well, that was adopted by our health minister about 6 years ago. We've been talking about this and everybody thinks it's done. When we look at these patient surveys, what we find is that the curve is pretty flat. Yes, there's a nice little upturn at the end, so maybe we're finally getting there. But the key message I wanted you to get from this is it takes time. It takes a long time to change people's attitudes and behavior. it's worth plugging away, and we need to measure to see whether we're getting anywhere. And I think we can just about begin to say we maybe are getting somewhere, but we're not there yet. We also can use these kinds of data for looking for segmenting the population. And this is an example where we looked at the difference between people who had no chronic conditions, one chronic condition, or multiple conditions. And we looked at their responses to some of these patient experience questions. And we found that people with chronic conditions really are having a worse, or reporting anyway, a worse time when they're in hospital. So we need to target our interventions to tackle this problem. And we heard about PROMs too. This is the EQ5D, which is much used around Europe, much beloved of health economists, and used very extensively in England. We now have a national PROMs program. We're measuring every person with one of 4 surgical procedures completes one of these questionnaires before and after surgery. So interesting, we've got a huge database now. And you'll notice that it covers issues like mobility, self-care, usual activities, and pain and discomfort. Important aspects of quality of life. But one of the drawbacks of this is it didn't start from what patients said were most important. And when you do that, you get a slightly different picture. This is how these data are presented. This is a funnel plot. It's one way of presenting the data. It may mean something to professionals. Actually, it doesn't mean very much to patients. And we need to do a lot more work on, how you make these kind of data meaningful so that patients can use them. But I said we'd been asking patients about what matters to them, what are the important outcomes, what should we be measuring in respect of their experience of illness and indeed the health outcomes. And they came up with these sorts of things. So many of these are what you might imagine would be there, but there note things like a sense of empowerment, a sense of control, a feeling of stigma because of the illness and the way it's treated, the burden of treatment, living in a feeling that you live in a safe environment, loneliness, and so on. So a much broader range of issues that patients say are important. We were focusing this on people with long-term conditions again. And because we saw this issue of multimorbidity and the lack of measures that were specifically designed for this as quite a problem. But as I said before, and I feel this strongly, and I think all the speakers have presented the same thing, measurement is never enough. Just measuring and sticking the data out there doesn't change anything. It's an important thing to do, but you need something else as well. And one of the best things you can do is work with patients to work out what the answers may be. We've done quite a lot in the UK in a system we call experience-based co-design. There are lots of names for these kinds of interventions. I don't worry too much about the names or the precise mechanisms because I think you need to find out your own way. But the basic message is, if you've got a problem and you've measured and you've identified it, then work with people who can help you fix it. And many patients are very willing to help you do that. So it's a long journey. We have learned quite a lot along the way. There is a lot of evidence that we can build on. One of the things we have learned is the kind of organizational factors that need to be in place if we want to achieve this kind of change to a person-centered system. We know the importance of strong, committed senior leadership. I think you have that in HAS, and indeed, I'm sure in many other French healthcare institutions. Where the senior leaders are really wanting to move in this direction, then you're more than half the way there. But you also need people whose job it is to think about this all the time, the dedicated champions. You must engage patients, whether they're patient organization representatives, associations, or whether they're individuals, or whether indeed it's a question of gathering together all the research. It must be part of this. And then you have to have very clear goals about what you're trying to achieve, often taking small steps rather than trying to do everything all at once. Embedding it in the organizational processes. So that means in your recruitment processes, in your appraisal processes, in your reward processes, in everything that you do in an organization, you need to be looking for people who will help you further this agenda. And then, of course, you have to pay some money to do it because it doesn't come cheap, but it's also can generate huge value, as we've seen. And then, of course, you do have to measure and look again to see whether you're achieving your goals. If you can do that, and I have no reason to think that that it's probably already happening in many parts of France. I know in England we struggle with it, but we have got some organizations who've really embedded this approach. And I don't think any of them would turn back from it. I think they see the value of it. And I hope that you've enjoyed this fascinating meeting. I found it fascinating, and can build on all the examples that you've heard from today. Thank you very much.
Merci beaucoup, Angela Coulter.
Thank you very much, Angela. Thank you indeed for having been our guest speaker and the thread through our discussions today. I'm going to hand the floor to Dominique, who is going to give us a few words as a conclusion. Thank you very much, Angela, for this very informative conclusion, which is a very clear roadmap for us all. And I think we all agree on the wealth of the content and discussions and the examples that were given today in the course of this symposium, and the need to involve patients, users, and medical professionals in this process. On behalf of my organization and my colleagues, I would like to thank all those who have contributed to make this a success. First and foremost, our speakers and guests who have fed into this very interesting, informative debate with their presentations, in particular those who have come from far afield, sometimes from across the Atlantic or neighboring countries. In fact, we should make the most of the fact that they are still within the European Union. And of course, those who are in charge of projects and our colleagues from the HAS who have contributed vastly to preparing this work. I think in particular, Gadi, Julien Prévert, David Laparette. Yes, a round of applause for all of these people who have been working in the background, behind the scenes. And of course, the organizing team and our moderator today. And of course, the whole communication team with Emmanuel Barra, and of course, with the special touch of Isabelle de Salle. And thank you to you all for having been here and actively participating in the debates in the course of today's discussions. Wish you all a safe trip home. And now you can immediately review the content of this symposium, because all the content will be made available in the next 15 minutes online. Thank you very much to everybody, and thank you for taking part. Bye-bye.